Hello everyone, I'm Dr. Priyanka Bansal. I'm an obstetrician and a gynecologist, and we all know recently on 5th March of this month, uh, our NEET PG exam has been conducted. So I would like to discuss the OBGY recalls. There were approximately 20 questions, so let's start. First, the obstetrics. So the first question was partograph. Cervix was fully dilated. There was meconium stained liquor. The fetal heart rate was decreasing. The station was +3 and the molding was +2. What will be the management? So if we understand the partograph reading, we all know that here is where the actually graphing we have to draw. This is a cervix, and cervix we have to show when we say fully dilated, it means it is 10 centimeters. So it will be somewhat in this area. It will be 10 centimeters. The liquor, we know it is mentioned in this area. If you can see, this is a liquor and it was meconium stained, which is an indication that the fetus was in stress. When the fetal heart rate it is written, it is decreasing, then again it is a sign that the fetal bradycardia is happening and the fetal stress is there. Station is at +3. We all know station is said in respect to the ischial spines. This means +3 means that 3 centimeters below the ischial spines. And that almost means the fetal head has touched the pelvic floor. The molding, however, was also 2 plus. Now, what is molding? Remember, when the baby has to deliver from the pelvic wall, certain changes in the skull of the baby has to happen so that accommodation of that skull into the pelvic bone has to happen. Because we know that baby's biggest and strongest part is the skull only. If skull is able to pass through the pelvic bone, then the body will definitely pass through it. So certain changes which happen in the skull, that is overlapping of the bones of the skull to go through the pelvic bone is known as molding. Now molding up to certain extent is normal. Molding can be graded as 1, 2 and 3. 1 means it is the bones are just touching each other. 2 means their bones are actually overlapping each other, but it is irreducible. And molding 3 grade means that the bones are overlapping each other, but that is not reducible. So 2 means that the bones have already overlapped, but it is kind of reducible. So how will you manage? So if you see, all this is definitely indicating that the baby is having fetal distress. Okay, the baby is in stress. And when we have that the cervix is fully dilated, we could have delivered with the help of forceps or vacuum. But we have to make attention over here for two important points. First point is that molding is present. So when I say that station is +3, it's actually not the baby head which is touching the pelvic floor. Because of so severe molding, we are actually feeling the molded area. The actual brain, the actual bone of the baby is still behind the +3 station. So this means that it is a cephalopelvic disproportion. The pelvis is small and baby's head has just accommodated up to +2, but still it's not able to come below it. And that is why the baby is already gone for stress. We can see that with the help of meconium and fetal heart rate decreasing. If you deliver with the help of forceps or vacuum, first of all, it is going to be time taking. Second, you require really good skills to perform forceps and vacuum. So it is always better to do an immediate cesarean section so that it is always good for the baby. We have to resuscitate because here the mother is as such no problem, but for the baby, immediate C-section will be definitely better. Because remember, if so much molding is there, it is not possible to apply vacuum because vacuum will not have a very good grip. Also, the forceps, if you apply, it requires good skill and then it requires a lot of time also sometimes, which can be very harmful for the baby. We can lose the baby in this situation. That is why the answer here will be immediate cesarean section because it's a case of CPD with pelvic distress. Moving to the second question. A female patient was diagnosed with ectopic pregnancy of mass 3 into 2 centimeters. There was no cardiac activity and the beta HCG was 2800 units. Patient was hemodynamically stable. How will you manage? The ectopic pregnancy basically has three managements. Okay, one is expectant management, which is actually not done nowadays. Second is medical management, and third is the surgical management. Now for the medical management, we have a certain criteria. Okay, first of all, there should be no hemodynamics instability. By this we mean that pulse should be normal, the pp should be recordable, the patient is stable in the sense there is no high temperature, patient is passing urine also. That shows that the cardiac output is still good and patient is hemodynamically stable. There is no tubal rupture. How will you find out? First of all, the patient will say a history of acute severe pain, and also on scanning, you will find hemoperitoneum. If these things are present, this means tubal rupture has happened. So, for medical management, no tubal rupture should be there. Fertility is desired. Now we know that if tube has ruptured, the surgical management will actually going to be salpingectomy, that is removal of the tube. But when the patient is requiring a fertility, of course, the patient has to be stable and the tube should not rupture. Then we can, and fertility is desired, we go for medical management. The gestational sac should be less than 3.5 centimeters. The beta HCG level should be less than 5,000. There should be no cardiac activity on ultrasound and willingness to follow up. If the patient is fulfilling all of these criteria, only then you will take the patient for medical management. And if you see that the mass is less than 3.5 centimeters, there is no cardiac activity, beta HCG is less than 5,000, and patient is stable. This means all the criteria for medical management is being fulfilled. Now, what will you give, oral or IM? Of course, we know oral. See, all the medicines when we give IV or IM, that obviously has more effects. And in ectopic pregnancy, we never give oral, okay? So it will be intramuscular single dose methotrexate. We know that single dose means ectopic pregnancy and multiple doses means in gestational trophoblastic diseases, we will give multiple doses. In ectopic, only a single dose of methotrexate is given. The dose is usually 1 milligram per kg, which is usually most of the patients we are giving 50 milligram intramuscular, okay? So the answer here will be B option. Moving to the third question, management of anemia when hemoglobin is 9 gram in 2 months or 7 weeks of pregnancy. Some students were saying it was 2 months, some were saying 7 weeks. Anyways, there's not much difference. The whole idea is that the patient is having in first trimester. The whole idea is that in the first trimester, the patient is having 9 grams. In pregnancy, we know that when the patient is having less than 12, that itself is a criteria for anemia. And if it is 10 to 10.9, it will be mild, okay? So in less than 10 or more than 7 to 10 actually. 7 to 10 is moderate, okay? So basically the patient is moderate anemia in the first trimester itself. So remember, usually we don't give iron in the first trimester when the hemoglobin is more than 10. But with the patient is coming with moderate anemia, we know that the hemoglobin will keep on falling down, which will have adverse effects on the mother as well as the fetus. So, of course, treatment for anemia with iron should be started. And as you can see in this flowchart, if it is less than 30 weeks, the treatment of iron deficiency will be oral iron. Okay, oral iron has to be started. Only if the patient is intolerant or non-compliant with the oral therapy, we will go for the parenteral therapies. Blood transfusion has very strict indications when the patient is having very severe anemia, that is less than 4, or the patient is already in cardiac failure. In those situations only we usually refer the or reserve the conditions for blood transfusion. So management of anemia will be 9 gram in 2 months or 7 weeks of pregnancy. So we will definitely start the treatment as soon as possible with the oral iron therapy. Okay, oral iron therapy has to be started. Okay, next question. 25 years female in second trimester of pregnancy with 2 healthy previous twins. What will be the OBS score? So a lot of questions are always asked on the twins. Understand what does gravida mean. Please understand, gravida means that the number of time patient has become pregnant irrespective of the outcome of the pregnancy. That means if she became pregnant and she had abortion, or she had ectopic, or she had preterm, or she had gestational trophoblastic neoplasia, or she had twins, whatever it is, it will be counted as pregnancy, that the score will be counted in gravida. Okay, so G1, that will be there. And of course, this is including the present pregnancy. Okay, and what does parity mean? Parity simply means the number of pregnancies which have crossed the period of viability, excluding the present pregnancy. Excluding the present pregnancy. Okay, so now if you see, now this patient is in second trimester and she already has 2 healthy previous twins. They always put twins for confusing the students, but remember, twins will not change the gravida or the parity score. So simple answer is going to be G2P1. That's it. Okay, G2 means she's second time pregnant. Previously she was also pregnant, and P will tell that whatever was the previous pregnancy that has crossed the period of viability. Sometimes we usually write G2P1L2. Now, this means that previous pregnancy had crossed the period of viability and those were twins. That's why live two babies are there, live two babies, okay? And normally, if suppose the previous pregnancy was singleton pregnancy, G2P1L1, okay? Only with this, you can tell that the previous pregnancy was twins. If I write G2P1, this is the answer, G2P1, only writing with this, I cannot tell that previous pregnancy was twins or previous pregnancy was singleton. But that, as I told, twins will not change this code. It will remain same. Okay. So G2P1L2 means previous pregnancy was twins. G2P1L1 means previous pregnancy was singleton. This time she is pregnant. That is why we made G2. Okay. Next question, question 5, a female with history of asthma, what cannot be used for induction of labor? It's a very direct question. We all know that carboprost is contraindicated in asthma. You should know the names, that prostaglandin E1, we know mesoprost. Mesoprost is specially reserved for termination of pregnancy and induction of labor, that is E1. And remember F2 alpha, that is the carboprost. Carboprost is given intramuscularly and asthma is the contraindication. Remember dinoprostone gel, this is also reserved for induction of labor at full term. That is prostaglandin E2. You should know this one. E1 is mesoprost, E2 is dinoprostone, and F2 alpha is carboprost. And carboprost is contraindicated in bronchial asthma, in heart disease, in hypertension, severe liver functions, glaucoma, and decompensated diabetes also. It should be stored below 60 degrees Celsius and half-life is about 2 years. Direct intramyometrial injection. Intramyometrial means in the muscle of the uterus. When in PPH, because we know carboprost has a very important role, so we give directly into the muscle of the uterus so that it has a faster onset of action and it is more effective. Okay. However, it's not licensed to be used like that, but we all use like that. Next question, multipara. Question 6, multipara presenting at 36 plus 6 weeks with transverse lie with adequate liquor and fetal weight is 2.8 kg. How will you manage? See, when they're asking a question, each and every hint they are giving has a significance. Each and every hint. Okay, so first hint is multipara. Okay, multipara. Second hint is the period of gestation. The baby is in transverse lie. Now, why they are giving you that hint? Ki bhai adequate liquor hai, fetal weight is 2.8 kg. Why? Because they want you to understand they are not looking for an answer of cesarean section. Okay. What can be the management? So it's multipara. When we say multipara, why they are saying that? Because multipara ka lax abdomen hota hai. You have space. Okay. So that baby उसमें turn कर सकता है या आप turn कर सकते हो. The POG, that is period of gestation, is 36 plus weeks. This means that external cephalic version जो होता है वो 36 weeks के बाद ही किया जाता है और approximately 37 weeks पे करा जाता है. Why? उससे पहले क्यों नहीं करते? क्योंकि बेबी वापस से फिर अपना abnormal lie में आ सकता है, इसलिए हम उसके बाद ही करते हैं. एडिक्वेट लाइकर का हिंट क्यों दे रहे हैं और फीटल वेट का हिंट क्यों दे रहे हैं? इसका ये दिखाना चाह रहे हैं कि बेबी इज गुड इनफ, बेबी इज हेल्दी इनफ, बहुत प्रीटर्म नहीं है और बहुत ज्यादा ओवरवेट नहीं है और एडिक्वेट लाइकर है. दिस मीन्स आप बेबी को टर्न कर सकते हो. ओके, प्लीज अंडरस्टैंड, वी इन बुक्स वी यूजुअली रीड ओनली फॉर ब्रीच दैट एक्सटर्नल केफालिक वर्जन इज रिजर्व्ड, बट ऑफ कोर्स इट इज कॉमन सेंस कि जब हम ब्रीच व्हेन द बेबी इज कंप्लीटली उल्टा, when the baby sir is ऊपर and नीचे पैर है, जब हम उसको पूरा उल्टा निकाल सकते हैं, तो of course when the baby is in transverse line, तो फिर तो हम उसको definitely जो सर transverse line में पड़ा है उसको तो बस नीचे तक डाल ही सकते हैं ना. That is a common sense of course. So external cephalic version will be the answer for this. Okay. Of course, there are certain indications, contraindications, but when the question itself is giving you all the favorable hints for external cephalic version, you should learn to pick up those hints. Okay. So this of course is for breech I am showing, but remember if yahan se external cephalic version for a transverse line, you just have to rotate like this. Of course, NST has to be monitored during the procedure and rule out other contraindications, but then that is not concerning this question. It's a very simple question. Multipara. Had it been primipara, then you will definitely not do ECV, but multipara means they are giving you all the hints that the patient is a candidate for ECV. Next question. 32 weeks pregnant female with difficulty in breathing and respiration, on examination, abdominal distension, but no tenderness. Fetal parts are not palpable, but fetal movements are normal. The symphysiofundal height is 41 centimeters. What is your diagnosis? Okay. So POG is 32 weeks, but when you measure it, the symphysiofundal height is 41 centimeters. So there's a huge difference and patient is having all these problems. So we know that in PIH, nothing of that sort will happen. In fact, in PIH, it's IUGR, isn't it? Whatever it is, the baby is going to be small. And that if you think breathing problem, difficulty problem, yes, that can be. But there will be, why there's excess of abdominal distension? Why fetal parts are not palpable? So of course, and they would have given a hint of BP. At least BP they will mention कि patient का BP ज़्यादा है. Nothing like that has been mentioned. Mother ascites. See, whenever there is mother ascites, this can be a differential diagnosis, I agree. But in that, remember, fetal parts will be felt, okay? Because ascites का मतलब क्या हुआ कि abdominal cavity में fluid collected है. Uterus में तो uterus तो normal है ना, तो fetal parts तो आपको अच्छे से feel होंगे ही when the examiner is examining that. But इसमें fetal parts are not palpable. This line is actually ruling out the maternal ascites, okay? Otherwise, other things can match. क्योंकि ascites है तो difficulty in breathing, respiration ये सब होगा. मैक्रोसोमिया मतलब बिग बेबी अगर होगा तो डेफिनेटली फीटल पार्ट्स तो फील होंगे ही ना. Fetal parts are not palpable. Again, this line is ruling out this diagnosis also. Polyhydramnios. So, of course, in polyhydramnios is fulfilling all these criteria because we know that in polyhydramnios there is excess of liquor in the uterine cavity, and there can be two main reasons. Pathologically, first of all, the baby is not able to swallow, or the baby is peeing so much. There can be a lot of kidney secretion or urine secretion from the baby, or the baby is not swallowing. So that is the main etiology of polyhydramnios, and mostly we know it is related with the diabetic mothers. Okay, so the answer will be polyhydramnios in this situation. Question 8. A pregnant female complains of dizziness on lying down and relief on sitting up and lying lateral. What is the reason? Again, it's a very direct question. Whenever antenatal patients are coming to us by the second trimester, we always advise them to lie on the left lateral side. The simple reason is that अगर वो सीधे लेटते हैं, then the uterus is going to compress the vena cava, okay, inferior vena cava. Now, when IVC is compressed, what is going to happen? The preload or the input to the heart is going to be decreased. जब इनपुट डिक्रीज होएगा तो आउटपुट भी डिक्रीज होएगा. तो आउटपुट डिक्रीज होएगा हार्ट का तो ऑफ कोर्स ब्रेन को कम ब्लड मिलेगा. And when she'll get up, she'll have a dizziness feeling because the brain is not getting good blood circulation. So I know decreased cerebral blood flow was, I think, also in the options, and venocaval compression is also there. But you see the main reason if you have to choose is a venal compression. क्योंकि venal compression की वजह से decreased cerebral blood flow हो रहा है, right? So we have to go to the root answer, and that will be venal cable compression. So there were these questions of OBS. Now we'll go for gynec. So question 9, 53 years old female having necrotizing lesion on cervix. On examination, it is involving the parametrium also. Treatment of the patient. So of course, the diagnosis is pretty clear. The age factor, see in gynae, age is a very, very important factor. It will always help you to diagnose what is the disease. Okay, she's having a necrotizing lesion on cervix. Age and this lesion, of course, we think it can be cancer cervix. Okay, and it is all involving the parametrium also. So definitely for cancers, you have to be very thorough with the stages. So parametrium, when parametrium, simply parametrium means अगर ये lateral pelvic wall है, तो यहाँ का जो connective tissue होता है, like broad ligament हो गया, endopelvic fascia हो गया, when that area is involved, that is known as a parametrium. Okay, so parametrium is involved. Then it is stage 2B. This we all know. Okay, we have to be very much aware of the stages of CA cervix especially. So when we know stage 2B, तो we know कि 2B में आते ही it is chemotherapy with radiation. That is the main treatment. Okay, after 2B, from 2B rather, there is no role of surgery. Okay, it is chemoradiation. So it's a very direct question. Parametrium has been involved. The answer is going to be chemoradiation. Next question, what is neoadjuvant therapy? I was not able to get the options for this, but remember, neoadjuvant therapy refers to systemic treatment of any cancer which is prior to surgical therapy. Okay, neoadjuvant. So it is adjuvant. Okay, neo means it is a new thing, but we are adjuvant. We are giving us an adjuvant therapy to the main treatment, and typically neoadjuvant has taken the form of chemotherapy. Although there is increasing interest, now endocrine therapy is also coming. So any therapy which you are giving before surgery, any therapy, it can be chemotherapy, that can be endocrine therapy before surgery, that is known as neoadjuvant therapy. Okay. Next question. Now this is infertile PCOS patient was given injection HMG for ovulation induction. She developed a complication. What is it? Now see again, catch the hints. Infertile, okay. PCOS. The patient is a known case of PCOS, okay. And she was given what injection? HMG. We know HMG are gonadotropin injections, which are given for the ovulation induction. So we know when because what is the main complication which all the IVF specialists are fearing of is the OHS, okay, ovarian hyperstimulation syndrome. Abhi, with the help of these hints, it's very easy to catch ki bhai, this is the ovary. You can understand, okay? And so many follicles have developed, okay? So basically, ovary got hyperstimulated. Instead of getting few like 15, 20, 30, we're getting some 60 follicles like that. So many follicles got recruited, and that is a complication. Why? Because we know that because of vascular endothelial growth factor, there is going to be extravasation of fluid in the third compartment, and the patient is going to have ascites and hypoproteinemia. She will have breathlessness, and a lot of complications can happen. The main reason is vascular endothelial growth factor. Okay, so answer is OHSS. But one thing I want to highlight over here is if these hints are not given, then it's definitely not easy to suspect कि ये theca lutein cyst है या PCOS है. Ovarian rupture of course नहीं होगा. Ovarian rupture means you will not get multiple cysts. Okay, you will get a single cyst and which also has ruptured. So there will be collection in the pouch of Douglas. That will be the main, and it will present with abdominal pain, acute. OHSS will be like not very acute, but it will be like in 2 to 3 days developing. Also, that is why I'm telling you that always pick up the hints. Already a PCOS patient है, उसको injection HMG दिया, तो complication PCOS तो नहीं हो सकता है. That is common sense. Now, theca lutein cyst and OHSS. If you really ask me, and I give you only the scan, so it's not very easy to tell कि कौन सा है. Okay, theca lutein cyst is also associated with GTN, and these cysts require no management. It's a very conservative management. GTN treat करते हैं तो cyst भी अपने आप resolve हो जाता है. That is why you have to learn to read the question and pick up the hints. Okay, so OHSS will be the answer over here. With the help of gonadotropins, you can see because of vascular endothelial growth factor, the whole pathology is happening. Next question, vaginal discharge. The husband is truck driver, cervical erosion is there, and query, empirical therapy. Now, why query means because some students were saying cervical erosion was mentioned, some were saying it was not mentioned. Okay. So now what is the main thing is vaginal discharge and husband is truck driver. Why are they telling that? Why are they putting this line that husband is truck driver? They want you to understand that the patient is basically STD. Okay, because we know truck drivers at a higher risk for STDs, so wife would have got STD from husband. So STDs, which are the common things, which are the common infections of PID? We know it's because of chlamydia or gonorrhea. Okay, and अगर आपको सिर्फ इतना भी समझ जाओगे तो it is cervicitis they are talking about. So if you understand this much, अगर cervical erosion था या नहीं था, whatever it is, but अगर husband is truck driver, this means they want you to think in terms कि भैया the patient is having PID. Okay, they don't want you to think that patient is having vaginitis. And also remember vaginal discharge. See, patient does not know that the discharge is coming from vagina or from the cervix. She will just say discharge is coming. Okay, for her thinking, it is from the vagina. But remember, even cervical discharge will come from the vagina only, isn't it? So cervical discharge or vaginal discharge is going to present as vaginal discharge only. Husband is truck driver. This is giving you the hint. And of course, if cervical erosion was mentioned, then definitely it is cervicitis. Okay. So empirical therapy, we all know this thing. Remember, for cervical discharge, it is the grey kit. Okay, it is the grey kit. Only for vaginitis or vaginal discharge, it is going to be the green kit. But in this case, the answer is this because of the two hints, that is truck driver husband and cervicitis is present. Next question. 16 years female with primary amenorrhea with cyclical lower abdomen pain, suprapubic bulge on upper rectal swelling. Now again, there was a little controversy. Some students were saying that swelling was written along the entire vaginal length, or some were saying only in the upper 1/3 it was swelled. Okay, so we know that ultimately we know that it is going to be outflow obstruction. Okay, this we can easily confirm. Why? Because patient is having cyclical lower abdomen pain and suprapubic bulge. This clearly shows that outflow ही बंद है. Otherwise, patient is menstruating inside and the blood is keeping on collecting. Now, we have to basically differentiate between imperforate hymen and transverse vaginal septum. Now, being honest, if the question was written entire vaginal length, then of course it is imperforate hymen. Okay, but if in the question it was in the upper one third, see if you see only this upper one third, this area, just change the color. If you see this area, one third, because if the transverse vaginal septum is there, it will not allow the blood to come in the lower two-third of vagina, and it will keep on collecting and collecting. So when you do a per rectal examination, okay, when you put your insert in the finger in the rectum, you will feel only this much will be collected blood. The lower two-third will be, of course, not having blood. It will not be swollen. So if the question was in the whole length of vagina, then the answer is imperforate hymen. If in the question it was in the upper one third, then of course the answer will be the transverse vaginal septum. So I hope that answers the question. It is a little, some students were saying like there was not a harmony in this question, but whatever was the question, the answer will be that. Okay, next question. Female with multiple sexual partners is coming with chief complaints of fever and swelling of labia majora. Identify the image. I guess image was given. So, of course, the hints are multiple sexual partners with chief complaint of fever. Fever, if she say, then of course it is infections. Okay. Now you will think, yes, it is a STD. It can be this thing. But remember, now the patient complaint is swelling of the labia majora. She is not having vaginal discharge. Nothing of that has been mentioned. So, of course, when the patient is having labia majora swelling with fever, you will think about Bartholin's abscess. Okay. With multiple sexual partners, yes, it can happen. Chlamydia, trichomonas, they will be definitely presenting with vaginal discharge history. And usually fever is not so severe, which has usually. Okay, lipoma will be completely asymptomatic. She will not have fever. And even history of multiple sexual partners will not be given in that. So in this, answer is going to be Bartholin abscess. Question 15, 23 years female, married for 6 months, has come to you as she's anxious to conceive. How will you manage her? See, the answer of the question is again very direct. Infertility, the definition by WHO is that after 12 months or more of regular unprotected sexual intercourse, unprotected, okay? So just remember, even if the patient is married for like 4 years, okay? But they say that we have been trying only since 6 months, then you will not term that patient as infertility, because they have been actively trying or they have been having unprotected sexual intercourse only since 6 months. Okay, so read the question. Now this patient is married only for 6 months. Okay, she's been married only for 6 months, then definitely she will not come under the category of infertility, and you will not start any treatment. Okay, usually we don't start any treatment. And the age factor, if you see, she's a young female. Had the same female was, if they have written 35 plus, suppose 37, 38, then of course you will start, basic investigations. But at least for a 23 years female married for 6 months, just reassure her. Okay. And you have to give counseling about what are the fertile days or all that. But you will not start any major treatment for her. Question 16, mother is diagnosed with CA cervix. What management should be done for daughter? Now remember, CA cervix is something which is not running in genetics. Okay, it does not run in families. Yes, ovarian cancer runs, endometrial cancer runs, breast cancer runs. Okay, if these are the history, there is a genetic component to this, but cervical cancer will not run in families. Because the major risk factors for cervical cancer, we know, is unprotected multiple sexual partners, and they will cause this HPV virus infection. Okay, so BRCA testing, we know, is for breast cancer. HPV testing, HPV testing is somewhat which everyone should undergo. Okay, especially for in fact all adolescents now, HPV vaccination has been implemented by the health Ministry of Health of our country. And PTEN testing is again, we know, is for the endometrial cancer. So management for the daughter will be HPV vaccination. Remember, HPV vaccination is available in 3 forms: Cervarix, Gardasil 9, and it can be started right from the age of 9 years. It can also be given to boys, not the Cervarix, but Gardasil and Gardasil 9, they can be given. And we know Cervarix is containing these 2 strains. Gardasil is containing 4 strains, and Gardasil 9, as the name is saying, it contains the 9 strains. Okay. One important update you should know is that Serum Institute of India recently launched an indigenous HPV vaccine against cervical cancer called Cervavac. Okay. So now in our country, we will be provided with a Indian brand, that is Cervavac. Next question, which of the following conditions in OT list you will post for hysteroscopy? Now, what is hysteroscopy? See, if you don't know what is that, at least try to make it out. Hystero means what? Uterus. Hysterectomy we say, okay? So uterus. And scopy means camera. So basically, with the help of camera, you are going to go inside the uterus. You will go inside the uterus. Okay. So of course, you will be able to do anything in hysteroscopy which is inside the uterus. Outside the uterus, you cannot do anything which which is outside the uterus when you are doing hysteroscopy. In laparoscopy means you are going from the abdomen of the patient. In that situation, you will do something which is outside the uterus, like any ovarian cyst, any tubal mass, any adnexal mass. But even uterine fibroid, that also we know can be done with laparoscopy. But remember, in the cavity, in the uterine cavity, whatever it is, that we will not do that with laparoscopy. We will do that with hysteroscopy. Okay. So that is why if you see subserous myoma, subserous means we know that it is in the outside. Okay. So this we will do with laparoscopy. Had the option been submucous, okay. So submucous myoma means it is inside the cavity. Then hysteroscopy will be the answer. Tumor and adnexa. Adnexa means it is near, over here, this area. This area is known as adnexa, right? The fallopian tubes, the ovaries, the broad ligament, all those tissues together are known as adnexa. So adnexal mass, again with the help of laparoscopy. Cervical polyp. For cervical polyp, which is outside only, cervix means, of course, you can see that polyp. You don't need to do that with hysteroscopy. That can be just simply done with instruments, okay? That does not require hystero or laparoscopy. So what is Asherman syndrome? I hope you all know that this is a normal uterus. Asherman syndrome simply means the cavity has been obliterated, okay, by bands. There is a lot of additions inside the uterine cavity. Typical history will be repeated DNCs, okay, or vigorous DNCs has been done by untrained staff. That can lead to Asherman syndrome. So only hysteroscopy, you will go inside and you will cut all these bands, okay, with the help of scissors. You will cut it. So the answer will be in this case Asherman syndrome, okay. Again, a question was asked on hysteroscopy. During hysteroscopic procedure, there is a fluid deficit of 2 liters. What are the immediate complications? Now, as I told you, hysteroscopy means you enter uterine cavity. But remember, whenever you enter the cavity, you have to inflate it. When you go in laparoscopy, how will you inflate? With the help of CO2 gas. Okay, that is why it's called this pneumoperitoneum. Pneumo means gas. With the help of gas, you have you inflated the abdominal cavity. In uterus also, sometimes CO2 is used, but majority of the times we use fluids. Okay, fluids can be RL, or if we are using monopolar and all that, then mannitol fluids can also be used. But remember, the main complications, because fluid deficit of 2 liters, this line means that suppose I have done the surgery, it took somewhat 1 hour, imagine, and total fluid which I have given is 6 liters, okay. Then since it's a cavity, ideally almost 6 liters should come out. But what happens is, there is some loss here and there. So we believe at least 1000 ml, fluid can be inside the body, 1000 ml, but not more than that. So in this case, there is fluid deficit of 2 liters. This means when I gave 6 liters, the fluid which came out, since hysteroscopy, it is a very active phenomenon. The fluid is going out through one pipe and fluid is coming out through another pipe. It's like that, okay? Fluid is going continuously inside and fluid is continuously coming out also. So we keep on measuring कि कितना अंदर गया और कितना बाहर आया. We have to keep on measuring that, especially when the surgeries are of long duration. Now, after the surgery, when I calculated कि भाई input तो कितना गया 6 liters क्या, लेकिन output कितना आया 4 liters आया. This means क्या हुआ, fluid deficit, I have a fluid deficit of 2 liters. And this of course means कि patient के अंदर 2 liter fluid extra चला गया है during the procedure. Okay. So what is the main complication is fluid overload. Of course, fluid overload 2 liters is a big amount and patient को fluid overload हो गया है. So of course the complication because of fluid overload can be pulmonary edema. Okay. So hysteroscopic complications, you should know, intraoperative, there's going to be pain. If instead of, I told you sometimes CO2 is also used for as a distension media, then air embolism can be a complication. Fluid overload, if it is viscous, Then pulmonary edema, anaphylaxis, coagulopathy, renal failure, all that can happen. If it is hypotonic, then electrolyte imbalance, encephalopathy, etc. can happen. Remember hemorrhage, perforation, thermal injuries, this can also happen. Post-operative hemorrhage, infection, hematometra. Hematometra means collection of blood inside the uterus. Okay, hematometra. And there can be others also. However, spread of malignancy, remember, we don't usually believe in this. This is an outdated thinking. Suppose endometrial cancer hai. So first investigation you will do is endometrial biopsy. That we will do with hysteroscope. So is there a fear of spreading of those endometrial cells into the peritoneum? The answer is no. Hysteroscopy is completely safe even if you are suspecting endometrial cancer. Okay, remember that. So the main concern in this question is fluid overload. Okay, fluid overload to the patient. Fluid deficit means when the technician or the doctor is calculating कि कितना अंदर गया और कितना बाहर आया. So I hope that answers the question. Next question is phenotypically female of height 155 centimeters with non-development of breast and pubic hair. On sonography, no internal genitalia organs are there. Bilateral inguinal mass is palpable. What is your diagnosis? So again, it's a little tricky question. It's again a very controversial question. The options were not very in harmony from the students. But remember, pick up the small hints. First of all, she is phenotypically female. Okay. Height is 155 centimeters. Height is good. Okay, 155 centimeters means a good height. There's no breast, there is no pubic hair. This means there is no estrogen or there is no testosterone. These are the hints you are getting. Okay, there's no estrogen, there is no testosterone. Height is good. You know, why I'm emphasizing height is good? क्योंकि Turner syndrome, कभी भी आप Turner syndrome के बारे में पढ़ते हैं, first word आता है short stature. First word is short stature. Always short stature. Okay. आई एग्री कि उसमें ब्रेस्ट डेवलपमेंट नहीं होता या प्यूबिक हेयर डेवलपमेंट नहीं होता बट शी विल बी शॉर्ट स्टेचर व्हेन दे आर सेइंग टिपिकली उन्होंने अलग से क्वेश्चन में मेंशन करा है कि हाइट 155 सेंटीमीटर्स है दिस मींस एग्जामिनर डज नॉट वांट यू टू थिंक ही शी इज अ टर्नर सिंड्रोम ओके अल्ट्रासाउंड में नो इंटरनल जेनाइटल ऑर्गन्स दिस मींस आपको यूट्रस नहीं दिखा और ऑफ कोर्स वी नो कि टर्नर सिंड्रोम्स में यूट्रस होता है उनमें ओवरीज नहीं होती. They're called as streak ovaries, but uterus hota hai. So again, Turner syndrome is ruled out. Bilateral inguinal mass is palpable. Now, this is something which is actually a little tricky thing, okay? क्योंकि सबको लगेगा कि भाई ये androgen insensitivity syndrome है. But what is complete androgen insensitivity syndrome? Understand that androgen insensitivity syndrome is what? In simple words, if I put simple words, कि actual में तो ये male है, लेकिन इसका testosterone जो है ना बॉडी उस टेस्टोस्टेरोन को लेकर सेंसिटिव नहीं है यानी कि उसका टेस्टोस्टेरोन जो भी बनाता है ना वो बॉडी में एक्ट नहीं कर पाता है. ठीक है, तो टेस्टोस्टेरोन तो है उसके पास लेकिन बॉडी के रिसेप्टर्स खराब हैं. इसीलिए वो टेस्टोस्टेरोन क्या करता है, एक वर्ड होता है जिसको हम बोलते हैं पेरिफेरल एरोमेटाइजेशन. पेरिफेरल एरोमेटाइजेशन का मतलब हुआ जो फैट होता है हमारी बॉडी में, फैट पेरिफेरीज में फैट होता है, एरोमेटेज एंजाइम, एक एरोमेटेज एंजाइम होता है उस फैट्स में जो कि टेस्टोस्टेरोन को ईस्ट्रोजन में कन्वर्ट कर देता है. ठीक है, तो अब क्या हुआ, इन मेल्स के पास टेस्टोस्टेरोन तो बहुत है तो ईस्ट्रोजन भी बहुत ज्यादा बन जाता है क्योंकि टेस्टोस्टेरोन के रिसेप्टर्स तो बोल रहे भाई तुम हमारे काम के नहीं हो, तो वो टेस्टोस्टेरोन ईस्ट्रोजन में कन्वर्ट होता जाता है एंड दिस ईस्ट्रोजन विल लीड टू द डेवलपमेंट ऑफ ब्रेस्ट्स. रिमेंबर दैट. ओके, this is a reason that despite being a male he has almost very good well developed breast, but then this is only incomplete. क्यों? क्योंकि complete insensitivity है body में, complete. Something that is called as partial androgen insensitivity syndrome. इसका मतलब वो बॉडी के रिसेप्टर्स पार्शियली टेस्टोस्टेरोन को लेकर सेंसिटिव है, पार्शियली सेंसिटिव है, मतलब कि उसके ब्रेस्ट डेवलपमेंट नहीं होंगे. क्यों? क्योंकि टेस्टोस्टेरोन अपना बाकी जगह काम करेगा, जो मेल्स का काम होता है टेस्टोस्टेरोन में वो करेगा, वो ब्रेस्ट डेवलपमेंट में काम नहीं करेगा. ये पार्शियल में होता है, लेकिन कंप्लीट में ऑलवेज ब्रेस्ट डेवलपमेंट विल बी प्रेजेंट. ओके, दैट इज व्हाई द ऑप्शंस दे हैव स्पेसिफिकली मेंशन कंप्लीट एंड्रोजन इनसेंसिटिविटी सिंड्रोम एंड व्हेन दे आर सेइंग कि ब्रेस्ट डेवलपमेंट नहीं है, इसका मतलब है दे डोंट वांट यू टू थिंक दिस ऑप्शन आल्सो. Okay, so sometimes we have to approach a question by ruling out. हमें आंसर नहीं भी मालूम है लेकिन हमें ये मालूम करना है कि ये तो नहीं होगा, ये तो नहीं होगा, तो बचा कौन सा, वो आंसर होगा. Sometimes we have to approach questions like that also. Coronal dysgenesis, of course we know this again cannot be the answer. Okay, because this is not matching with anything and bilateral inguinal mass palpable. So it can be possible कि वो actual में hernia हो, उसको जो patient है उसकी actual hernia हो सकता है, or there can be a mass palpable, but definitely it was not going to be complete androgen insensitivity syndrome क्योंकि उनमें breast development होता है. So ultimately we are left with hypergonadotrophic hypogonadism. This means simply that जो भी gonads है patient के, चाहे ovaries हैं, चाहे testes हैं, they are not functioning, they are not working. And yes, of course, no internal genital organs sometimes can be associated with that. It can be associated, okay? But this is the only option which is actually fulfilling all these criteria. उसके अलावा और कोई option is not fulfilling the question. Okay, so answer please will be by ruling out other options will be hypergonadotrophic hypogonadism. Question 20. What is the disadvantage of laparoscopic hysterectomy over total abdominal hysterectomy? So when I say TH, it means open hysterectomy. Okay, understand that. So basically the question is asking laparoscopy का open पे क्या disadvantage है? Remember, you know laparoscopy has now become the standard of treatment for hysterectomies almost everywhere क्योंकि उसमें blood loss कम होता है, healing बहुत जल्दी होती है और बहुत कम pain होता है. But yes, in laparoscopy, we don't use suture materials, okay? We use cautery, okay? We use monopolars, bipolars, and of course, the major risk with that is going to be electric burns, okay? Electric burns open में नहीं होता क्योंकि उधर हम suture material use करते हैं. Laparoscopy में हम cautery की help से सारे ligaments, सारे vessels को cauterize करते हैं. So of course, there is a risk of electric burns. And unfortunately, it is sometimes missed on the OT table and बाद में recognize होता है. So delayed recognition of electric burns. This is a complication, fortunately rare complication, but yes, this is a disadvantage over open surgeries. So answer is going to be C. I think this is the last question. Patient complains of vaginitis. Trichomonas vaginalis was diagnosed. Which of the following is true? Okay. So again, Trichomonas vaginalis के बारे में you should know. It has twitching motility. Vaginal secretions show cyst. It cannot be cultured. It is not sexually active. It's actually a very direct question. We know that Trichomonas has flagellae. Okay. We know that these are the flagellae. And of course, this is the parasite which is having motility. Okay. Motility is definitely seen in this parasite. So this answer is right, and secretion shows this. That's not right. It can be definitely cultured, and it is it is by sexual infection. Okay. So I think with this we come to the end, and I would just like to tell you that in OBS total there were 8 questions. In gynae there were 13 questions. So remember now they are more emphasizing more on gynae, and especially if you see about laparoscopy, hysteroscopy, 3 questions were there. So keep updating yourself about PID. Again 3 questions, cervical cancer 3 questions, almost primary amenorrhea 2 questions were there, infertility 2 questions. Of course, OBS is also important, but remember now the focus is shifting more on gynae and not on obstetrics. So make sure your gynae is very strong. Okay, and at the end I would just like to say that please it's very difficult, I know, to come back and go through a recall session, revise your questions. It can be a nightmare. It requires a lot of courage, of course, but the two very advantages of doing so is, first of all, you will learn your mistakes so that in next exam, if at all you have to appear, you know that this is the answer. And second thing is, ultimately we are all here to increase our knowledge. Okay, what we didn't know, at least we know now. Our knowledge has to increase every time. I would just like to, that is why end by the saying, our greatest glory is not in never falling, but in rising every time we fall. Thank you so much. In case you have any doubts, please mail me, which the mail ID is already on the first slide of my PPGs. Thank you.